During this video, Recovery People is going to introduce a unifying service framework for peer recovery organizations for your consideration. Recovery People is a peer-led and governed nonprofit that's building a brighter future for Texans in recovery. We're all about normalizing recovery, protecting people in recovery, strengthening the recovery profession and field, and increasing access and opportunities for people in recovery. Our hope is by completing this video that you'll achieve certain learning objectives. You'll be able to list at least 3 characteristics of peer recovery organizations that we call PROs, explain why PRO services are difficult to communicate, give an example of how an inclusive, unifying service framework has advanced the recovery field, list and price 3 standard lines of service provided by PROs, create a PRO service menu by bundling or unbundling lines of service, discuss the integration of PRO lines of service within the behavioral health and primary care continuums of care, and describe the co-location of PRO services in clinical settings. So what are peer recovery organizations? Peer recovery organizations, or PROs, are a collection of business models that share key characteristics, which in turn offer core competencies. When effectively leveraged, these core competencies can lead to competitive advantages over other organizations or non-peer recovery organizations. We've identified key characteristics that PROs share. They include they're peer-run and peer-governed, they're recovery-oriented, they're community-centered, and most often, they're nonprofits. In a separate video, we'll go in much more depth about each one of these characteristics, but for the purpose of this video, we wanted to provide a high-level overview. We also want to acknowledge that PROs identify themselves in different ways. Some really identify themselves as how they're governed. That includes recovery community organizations, consumer-operated service providers. Others really identify or self-identify with their service setting. Recovery housing, peer respites, recovery high schools, collegiate recovery, recovery cafes, community centers. And finally, there are a group of PROs that really are organized around who they connect with. That includes alternative peer groups for youth, military peer veteran network, and winner circle for individuals that are reentering from the criminal justice system. So why is it so difficult for PROs to communicate what they're selling? And likewise, why is it difficult for payers to understand what they're buying from PROs? Well, like all services, PRO services are intangible. Where goods such as cars and clothes and pencils are tangible, services like recovery support services are intangible. This makes them more difficult to market and manage, compare, value and purchase, evaluate and research, as well as deliver, especially replicate consistently and with fidelity. One of the main issues that we see is that there can be experience bias. Customers, payers, and stakeholders may inadvertently interpret a service through a lens that they're more familiar with. This can bias their perception or understanding. So it's worthwhile thinking of what types of services payers might be more familiar with than PRO services. The obvious example is going to be treatment services, clinical services. Many payers are accustomed and familiar with those types of services. So when we describe PRO services, they may immediately jump to some algorithm of clinical services, or maybe they're accustomed to pay for housing. And so when we talk about a PRO service, they may immediately think of the housing portion of a recovery home and not the recovery milieu and environment and recovery support provided within it. So we really need to be thinking of how do we overcome experience bias. We should also be thinking about what's the common language that we're using in the recovery movement today, and is that helpful in communicating what PROs are providing? So some examples of common language can be recovery support service, or RSS, which is defined as non-clinical services that support recovery. A close cousin of RSS is peer recovery support services, or PRSS, which are recovery support services that are specifically designed, developed, and delivered by peers. And when I use the word peer in this context, I'm talking about persons with lived experience. And many people are becoming more and more familiar with peer specialist services. These are recovery support services or non-clinical services that are delivered specifically by this credentialed role called peer specialist. So reflecting on these common terms, how well do they help us market or merchandise peer recovery organization services? Well, I would argue that the first two, although they're great words, are too general for what we're trying to define as peer recovery services or peer recovery organization services. Yes, PRO services do meet the definition of RSS and PRSS, but we need to be a little bit more specific. The third around peer specialist services is very specific definition and doesn't capture all the types of services that PROs provide. So let's go back to this familiar chart, or one that we've showed you before. It really maps out the different variations of peer recovery organizations. And we could also say that it maps out the fragmentation or the silos within the peer recovery organization. While this is not a comprehensive list of peer recovery organizations, you can start seeing some service themes and patterns. So PRO characteristics provide them with unique core competencies and in turn competitive advantages. While this is helpful in pitching a peer recovery organization's value proposition, payers will likely not understand the organization model as the service unto itself. In other words, PROs such as recovery community organizations and consumer service, COSPs, consumer operated service providers, are who the payers pay, not what they're paying for. PROs sometimes view the setting as the service, and they can self-identify as that setting, such as these examples. But payers may overly focus on the physical structure, that experience bias that we were talking about earlier, because it's more familiar. That's in contrast to really understanding that what we're talking about from a service delivery is the recovery environment within the setting. That's what makes it special. And finally, payers definitely want to know who the PRO's target audience is, or priority population, but they also want to know what services the PRO is providing to them. So if we only elevate the PRO description of the target audience, they may not fully understand, so what services are being provided. So how do we best merchandise PRO services? And is there a PRO success story that we can build upon? And the answer is yes. We can take a look at recovery residences as a case study. So even now, and definitely back in 2010, when the National Alliance for Recovery Residences first started looking at the diversity and the fragmentation of the recovery housing industry across the United States, there were all kinds of words. Oxford House, sober living, recovery homes, quarter house, halfway house, three-quarter house, therapeutic community, the Florida model. So many different words and that are still in use, but how people use those words and what they were describing from a service delivery perspective really varied from region to region and state to state. So it was always left with this question, what's what? So that's when the National Alliance for Recovery Residences, or NAR, developed levels of support. They identified 4 general types of recovery residences and listed them from levels 1, 2, 3, and 4. And from this graphic, you can see that the way that they distinguish between the service bundles is by the services that they bundle, such as all of them provide alcohol and illicit drug-free housing. All of them provide a recovery supportive environment or a milieu. And then as we move up into the higher levels of support, you start seeing some providing peer specialist services, life skills development, and at the highest level, clinical services. You'll also notice that within the little housing graphic, you'll see different representation of staffing and governance structure. So this is a very simple way of describing and organizing a very complex and diverse landscape of recovery housing. It's important to note that what NAR did was just define what existed out there. And the levels, one level is not better than another. The levels of support cost effectively match the diverse and evolving needs with persons with substance use disorder. So can we take that example and build upon it? What are the universal lines of service that all PROs use to build their service menu? And when I say lines of service, which is also known as lines of business, this is what describes the distinct area of a company's operational focused, a company's operations that it's focused on a specific set of related services. They often have their own management structure and strategic objectives. I like thinking about it as building blocks that are bundled to create a service or service menu. So not only do lines of service help us better merchandise peer recovery organization services, they're also going to help a peer recovery organization determine the cost and price of those services. So we're getting well, I don't want to use two birds with one stone because that's not very trauma informed, but we're getting lots of different advantages by using this line of service concept. So we've offered up that there are four basic peer recovery organization lines of service: the recovery milieu, peer specialist services, skills development, and then a catch-all other non-clinical services category. Let's take a closer look at each. With regards to recovery milieu, these are safe, supportive social environments that cultivate recovery capital by promoting social bonds, prosumer activity such as mutual aid, and a sense of community. Social environments are often cultivated where people live, where people work or learn, or where people connect. So again, I'm not talking about the house where people live. I'm talking about the environment and culture and connectivity and ecosystem within that house. Another example would be, I'm not talking about the school building. I'm talking about that ecosystem that's cultivated within that recovery high school. So when we look at how to operationalize or cost out building a recovery milieu, we naturally need to look at the staffing. There needs to be staff that's responsible for cultivating and maintaining the recovery supportive social environment and cultivating the interactions that happen within it. There's different strategies from a staffing perspective. In some cases, it's democratically run. All volunteers, you have elected leadership that serve in this role. In other situations, there's a dedicated, trained, and perhaps employed staff, peer staff, that's responsible for this. I think it's important to note that the individual who's responsible for cultivating the milieu is different than a peer specialist. Peer specialist and this recovery milieu role actually have role conflict. In other words, you wouldn't want someone to be your house manager and your peer specialist at the same time. It's not possible. You would want to have one individual as your house manager and another individual as your peer specialist. Speaking of peer specialists, let's move to peer specialist services. This service is much more widely recognized because in 2007, the Center for Medicaid and Medicare Services listed this as a reimbursable service. Since then, many states, and including Texas, have adopted this service and codified a definition within their respective states. So, for example, the definition of peer specialist services in Texas can be found in the Texas Administrative Code. And it reads, peer specialist services are voluntary, recovery-oriented, person-centered, relationship-focused, and trauma-informed services that may be provided individually or in a group. This includes recovery and wellness support, and that's described as including providing information on and support with planning for recovery. It also can include mentoring, which is described as including services as a role model or providing assistance in finding needed community resources and services. And finally, it includes advocacy, which is described as providing support in stressful or urgent situations and helping to ensure that a recipient's rights are respected. So when we think about how do we cost out or operationalize peer specialist services, once again, we need to think about staffing. But in this case, staffing, the key direct support service person is a peer specialist. And you would think about, what is that peer specialist caseload? In addition, peer specialists should have a qualified supervisor. Next, let's take a look at the line of service that we're describing as skills development. These are structured educational activities that promote recovery. They're measured in terms of the knowledge and skills gained and or ability to apply knowledge and skills in real-world situations through practical tasks and projects. When we think about how do we cost this out, how do we price it out, how do we operationalize, no surprise, we need to think about staffing. In this situation, we're thinking about somebody that is trained or certified to deliver the particular skills development that you're offering. Lastly is the catch-all line of service that we're calling other non-clinical. These are services that meet the needs of a targeted population, and they can include housing, schools such as secondary education, a drop-in center, transportation, food and beverage, supportive employment, or other. When we think about costing or operationalizing this, it can get a little bit more complicated. First, you need to be thinking about whether you need to purchase or lease an asset related to this non-clinical service. Of course, you have to think about staffing. So you may need to hire a contract required staff, and this may include, who's going to repair and maintain the asset in a safe and operational manner. And then lastly, you should think about, do you need to adhere to local, state, or federal laws that are required by this particular service? When we're thinking about recovery support services, most of them are not, they're non-clinical, thus not licensed or regulated in the same way that other services would be. But once we start getting into some of these other non-clinical services, there can be and often are local, state, or federal laws that you should keep in mind. It's helpful for us to think about the peer recovery organization's lines of service in terms of how defendable they are, meaning how easy is it or hard is it for another type of organization to replicate these lines of service. So on a scale of 1 to 10, we can rank these different services. Let's start with recovery milieu. So think about the recovery milieu, this recovery supportive social environment. And would you say that it's very difficult for other organizations to replicate this, or is it very easy for them to replicate this? Well, as I think about it, this is a core competency of peer recovery organizations. Peer recovery organizations have the unique characteristics that allow them to cultivate recovery milieus, recovery environments. Other type of organizations that don't have the combination of characteristics that peer recovery organizations do would find it very difficult, if not impossible, to cultivate the same type of recovery milieu that peer recovery organizations can. Let's take a look at the next line of service, which is peer specialist services. Peer recovery organizations invented peer specialist services and provided peer specialist services long before the government and insurance decided to reimburse for them. So back then, one may have said that it would be very difficult for other organizations to replicate it because it wasn't even on their radar. But as I mentioned before, in 2007, Medicaid and Medicare Services, the Center for Medicaid and Medicare Services, which is known as CMS, defined peer specialist services as services delivered by certified peer specialists. What they didn't define it as is services offered by peer recovery organizations. So that detached peer specialist services from PROs, and really it's any organization that can hire a peer specialist can provide peer specialist services. So when we're looking at this scale of how easy or difficult it is for other organizations to provide this service, it's definitely easier than the recovery milieu. Some could argue that it's very easy. Others would argue, well, but what's the quality of the service that they're providing? There's an argument to be made that peer recovery organizations can supervise and support peer specialists better than non-PROs. So it's falling somewhere in between very hard and very easy. Next, taking a look at skills development. Would you consider skills development very difficult for other organizations to replicate or very easy for other organizations to replicate? I think that we could settle on that it's relatively easy for other organizations to offer skills development. They make it look a little different, but there's no barriers of them offering these services. And finally, going to the other non-clinical service category, again, I would say that it's relatively easy for other types of organizations to provide these non-clinical services compared to peer recovery organizations. So why does this matter? Well, it means that the service that peer recovery organizations do best, that makes them special, that provides them the most core competency is the recovery milieu. So next, we're going to take a look at how do we combine these different services, bundle them into a service offering or menu. PRO lines of service can be bundled or unbundled to create a menu of services that meets the needs of a particular population. That said, universal lines of service offer a unifying common language while also allowing for variation and customization. So here's some examples. So we could describe a recovery cafe as the recovery milieu plus a cafe, which is an example of other non-clinical service. Next, we could describe a recovery community center as the recovery milieu plus peer specialist services plus skills development plus the center. Another example would be Oxford House. We could describe an Oxford House using this universal language of lines of service to be a recovery milieu plus housing. And the final example I have here is a level 3 recovery residence, which could be described as recovery milieu plus peer specialist services plus skills development plus housing. So what I want to stress is that the bundling of services can really be an advantage to peer recovery organizations. The graphic on the left is as an example of a peer recovery organization that is bundling peer specialist services, skills development, the recovery milieu, and a center. We're starting to see more and more organizations integrating peer specialists into their business setting, their organization. But I think we should be clear, like on the right-hand side, here's a non-peer recovery organization that's added peer services. They also provide skills development. It's also located in a center, and they add clinical services. we should, and while peer specialist services undoubtedly benefits this non-peer recovery organization and its clients, it's not the same as peer specialist services that are being provided by and in the context of a peer recovery organization. So, how do we describe this integration of services? How have PRO services been integrated into the larger service continuums? So first, let's take a look at the word integration and what that means to different people. In the business world, business integration is the process of one company acquiring another company and merging the operations. In the healthcare industry, healthcare integration is the process of coordinating and connecting different components of the healthcare system. So you've oftentimes heard people talk about the integration of recovery into either behavioral health or to primary care. But there's different kinds of integration. This chart shows the range from minimally coordinated, which is the column to the most left, to co-located, which is the column in the center, all the way on the right hand of the spectrum to fully integrated. When we talk about minimally coordinated, these are separate locations with separate systems that rarely communicate. It's really driven by a provider need as to whether the two organizations are communicating. When we look at co-located, that generally describes the services being in the same location, yet using two separate operating systems. They do communicate more regularly, and this is really around their shared participants or clients. And then fully integrated is same location, integrated systems, and they communicate often. They often think of themselves as a team or the team care concept. So we can use some get some specific examples of how peer recovery organization services are being integrated into behavior health. And when I talk about behavior health, I'm talking about services for individuals with mental health and substance use issues. The graphic there to the right is that kind of fan chart is typically how people talk about the continuum of care. Was developed by the Institute of Medicines and Medicine, and it's described as the behavioral health continuum of care model. As you see, it moves through promotion, prevention, treatment, and then has recovery all the way to the right. So examples of integrating could be if a peer recovery organization added prevention services, harm reduction services, or treatment services. And historically, we have seen different peer recovery organizations add these different services and kind of migrate or expand their service and sometimes change their identity. Many of those organizations may not even see themselves as peer recovery organizations anymore because they're identifying with providing one of these other service products that may be better funded. In more recent history, we have seen non-peer recovery organizations start adding recovery support services. And this was specifically when funding for recovery support services became available. We can also see integration examples in primary care. This would be if a PRO opened a federally qualified health clinic, FQHC. And I know that sounds like a lot, but we have seen examples of peer recovery organizations opening FQHCs in the United States. We've also seen peer recovery organizations open office-based opiate treatment, OBOTs. On the other hand, we've started seeing federally qualified health clinics being interested in adding recovery support services in-house. And that's when they would hire a peer specialist to offer these recovery support. So integration, there's some advantages and disadvantages. First, we can take a look at the advantages. It provides a potential for more revenue, more services per client. That creates some efficiencies there. Again, more efficient and actually more control. There's also some disadvantages. There's a potential for scope creep. That can lead to less fidelity and lower quality. A organization can lose their specialty, lose their core competency, and organizations can become less flexible and less adaptable, which means they could be less sustainable. And finally, because of all this, they could be less efficient. So we have seen some examples of co-location. Remember in the integration spectrum, that middle column was co-location. And the example would be embedded peer recovery organization services. A peer specialist who are employed and supervised by the PRO are embedded in an emergency room to engage individuals who overdosed and act as a bridge back to the community-based resources. Graphically, we can think about this chart again. Whereas on the left-hand side, you have the peer recovery organization with its bundled services that is providing outreach services or embedding their peer specialist over into that non-peer recovery organization setting or clinical setting in this case. That would allow both organizations to do what they're best at, and it would also allow individuals that are first engaged within the clinical setting have access to a well-supervised peer specialist that then bridges them to long-term engagement within the community. That is all that we have prepared for this presentation. This is a framework that we are putting out for public comment. We're very interested in your thoughts, what you liked, what you didn't like, any ways that we can improve. We encourage you to contact us at info@recoverypeople.org.